All right, welcome back for chapter 14 of your EMTB curriculum book. Going over BLS Resuscitation this time. Excuse me, not Corona. So what we got this evening for this lecture is going to be covering pretty much the basic tenets of CPR. What I want to make sure that we all have is the knowledge of the basics. I can tell you now that CPR is a huge important part of what we do. And if we master nothing else in this EMT program, we need to master CPR and the components therein. EMS is expected to be really good at running a code, and we should be good at running a code. It's one thing to have this, team of people in the ER that's well lit with a, highly trained medical professional doctor there to help guide your treatment and stuff you're doing and things you're trying. It's a whole nother thing to be performing CPR up 10 flights of stairs and the patient's 400 pounds wedged between the bathroom and the sink or the tub and the toilet. That sounds like it sounds like rhetoric, but it's not. It's fact. From time to time, it has happened to me. It will happen to you, and it's part of what EMS is. We're one of the last few professions that are, still making house calls and still meeting patients where they're at and meeting these needs of these patients. So I want you to pay close attention today to this. Now, a lot of you have actually been trained in CPR already. And a lot of you have been trained by me. The majority of you already have your CPR cards. So this will be a quick and easy chapter for you, but don't besmirch this material as small stuff. It ain't small potatoes. It is definitely a highly impactful and important part of who you are as an EMT and as a provider. This is when things have gone their worst. Worst case scenario of any call we run is what? Patient codes and needs CPR and needs BLS resuscitation. So this is us at that worst case scenario. Now, it'll never be 100% comfortable, but the more you do it, the better you get at it. And the more you train at it, the better you get at it. I promise you, if you follow all the steps and you learn how to dance this dance, you can resurrect the dead. Yes, you can resurrect the dead. Now, this is not, the power of love, or it's not the power of the Almighty. This ain't Lazarus. This is a whole different thing. This is us using the most up-to-date scientific methodology as formed and compulated by the American Heart Association. They have done countless studies and are continuing to research and perform studies and find what the best methods going forward are. So how vitally important is it for us to know this? Extremely. I'm also very big at pushing all of you to think about becoming CPR instructors once you're an EMT. That way you can go to your own communities and make a big impact. A big impact. I think it was Picasso that said that find out what your gift is and then give it away. You guys will be able to go, and if you want to charge people, that's on you. But I think that we should all do that as a public service and for free, give it out to people. Teach people how to do CPR. The numbers don't lie. The numbers may have changed since I did this research and wrote this paper, but bystander CPR. If we go out and we teach CPR to bystanders, community lay personnel, and they perform said CPR on a person that we respond to in our ambulance, there is a 47% higher chance of survivability if bystander CPR is applied. That was information I gathered from a journal article written by American Heart Association called Circulation. The numbers may have changed now, but I doubt it's changed much. Basically, what is half of nothing? Nothing. Half of something? Still something. So even if somebody's sitting there doing on hands-only CPR, they're increasing the likelihood of that patient surviving and living to see another day. That patient could go back to work in a few weeks. That patient could get to hug their grandkids again one day. This is really up to you and how well you perform steps to the dance. So what else do I think about it? Well, I think that Seattle, Washington has the highest resuscitation rate in the country. They have you are 2 to 3 times higher likely to survive a cardiac arrest out there. That is a verifiable fact. Look it up yourself. Google it. Everybody take a minute and Google it. Seattle, Washington, King County EMS. Out there, CPR is a part of the high school curriculum. There is a 67% chance that somebody will perform CPR on you if you just fall out there. So imagine like Coffee Bro from the Seattle Starbucks. Oh no, bro, let me put my man bun up. Dude, you call 911. I'm going to start compressions, bro. And that's what's happening. There's a 67% chance that somebody will do some CPR or first responding to you. And that gives you a 47% higher chance of survival. Now, you are now taking on the role of the EMT, the first responder, the emergency medical tech. You're going to show up and be who they have called. You are the cavalry now. So when you get there, you need to take over the scene, get as much information as possible, and perform picture-perfect CPR. As a paramedic, I can do some advanced things that are pretty cool, but nothing will save a patient's life more than actually performing picture-perfect CPR. Picture-perfect CPR. I'm gonna go ahead and share my screen now, and we'll get this thing cooking and moving. All right, so we're ready to roll, and we're ready to roll. Let me move you guys over here. So I'm not going to beat a dead horse tonight if you've already CPR certified, but let's just talk about it. So we want to talk about the principles of basic life support. Basic principles are what? The heart's not beating. You got to squish it between the sternum and the backbone to perform artificial heartbeats to move blood throughout the patient's body. What does blood do if it don't move? It sits, it coagulates, and it forms clots. And the cells, what do? Well, they go without oxygen. So they form lactic acid and they become acidic. And then all these issues are starting to pile up. The patient gets cold, they get coagulopathy issues, and they also become acidic. That's the triad of death. So elements of CPR, we got non-invasive emergency life-saving care used to treat medical conditions, including airway obstruction, respiratory arrest, and cardiac arrest. Now, what's the difference? An airway obstruction is something is in this airway blocking flow of air to your lungs. Remember, the trachea is one pipe, one conduit of air. If it is blocked, there is no other route of air to get in here. So we have to make sure the airway is clear and patent and usable. So by doing that, we will assess patients' airway as soon as we meet them. Now, let's say I show up and you say, hey, Josh, how you been, bud? Oh, okay. You're alert, you're oriented, you're talking to me, so you know who I am, where I'm at. You're talking, so your airway is open. I do not mind when a baby is screaming. It tells me their airway is open. I like adults to be quiet and sedated and babies to be loud and screaming. As a paramedic, in real life, I want everyone sedated. Kidding. So what about respiratory arrest? So if arrest, what does that mean? The term arrest, it means to stop, quit. So that means that they may still have a heartbeat for now, but they're not breathing. They have what is called apnea. Apnea, A meaning without, nea meaning breathing. The terms, apnea, without breathing. Tachypnea, tachy meaning fast. That means they're breathing faster than 20 times a minute. That means they're breathing too fast. Bradypnea is breathing below 12 times a minute. That is slow breathing. Brady means slow. All right. What about orthopnea? Ortho. That means positional breathing issues. What about dyspnea? Dyspnea. National Register is not going to say, hey, this patient's having trouble breathing. What you going to do about it? They're going to say the patient's got dyspnea. They're going to use medical terms on you. Once you get out in the field, we can speak a little bit more plainly, but they want to know that you know what you're talking about. So making sure you're strong on your med term will be very beneficial to you. So respiratory symptoms. Then we have cardiac arrest. Cardiac, heart arrest. The heart's not beating. There is no pulse. So elements that we're going to talk about is we're going to focus on the ABCs: airway, breathing, circulation. Airway, is there an obstruction? Is it open? Is it patent? Breathing, are they breathing? Are they breathing too fast? Are they breathing too slow? It's not just are they breathing enough to satisfy an adequate amount of breathing to have a good flow and good oxygen exchange? That's a question. Are they breathing? Are they breathing enough? Are they breathing deep enough? These are questions we have to ask ourselves and of the patient. So then we have circulation. Is there cardiac arrest or severe bleeding issues? So in a perfect world, only seconds will pass before you understand that a patient needs BLS treatment, ideally. Again, patients don't suddenly deteriorate. Healthcare workers suddenly notice. They suddenly notice. So hopefully it's only seconds, but as soon as you recognize a problem, you need to jump on it, Johnny, on the spot and be working that thing. So when you do take a pulse, it should take you at least 5 seconds, but no longer than 10 seconds. Your patients will not suffer brain damage and die because somebody doesn't intubate them. They will suffer in brain damage and possibly die if you don't ventilate them. That's a skill the BLS provider, the EMTB, can do. See, when I ventilate somebody, I take the bag valve mask and I form a seal, CE, on their face. I lift their chin up and I pull their face into my mask, and then I give a squeeze of the bag. Over a full second, I give enough breath to allow the chest to rise. I'm not trying to pop their lung off. That'd be bad. But I am artificially ventilating this patient, making sure they're not going without oxygen and ventilation. There is a difference in oxygenation and ventilation. Difference being ventilation is actually moving air in and out of a patient's chest. Oxygenation is actually putting oxygen molecules on hemoglobin and helping to form gas exchange. So your patients won't suffer brain damage if you're ventilating them. You have to recognize that they need that, though. So permanent brain damage is possible if the brain is without oxygen for 4 to 6 minutes. We talked about the cells in previous lectures. We talked about organic tissue needing blood flow and oxygen. If I take my finger, wrap a string around it, it'll turn red, blue, purple, black, and die. My brain tissue is the same way. Not that it's changing colors, but it is going to become ischemic. Ischemic means without oxygen. And then it will die off. And if I lose any more brain cells, I'm going to be in big trouble. So we have to avoid that in our patients here. Time is money. Time is brain. Time is brain. What does that mean? That means that the more time you spend fiddle farting around, the more brain tissue this patient likely is to lose. At 0 to 1 minutes being without oxygen, the patient will start to experience some cardiac irritability. 0 to 4 minutes, brain damage is possible, but not likely yet. 4 to 6 minutes, brain damage is very possible. And 6 to 10 minutes, brain damage, very likely, highly likely. More than 10 minutes, there is irreversible brain damage. We are now looking at a cucumber or a vegetable. They won't have, if you do resuscitate them, they will not have the quality of life that they ever had before. They will probably be on a machine to breathe, all kinds of things. I mean, it's just not a great thing. That's why we have to intervene up here in a timely fashion. Now, I have gone to cardiac arrest, and they had to have been down well past the 4 to 6 minute range before I even got there. We try and be fast and efficient, but if we're level 0 and I'm coming from across town, I'm doing the best I can, but might have been down a few minutes. If the patient is viable, and by viable, I mean, are they within metrics for resuscitation? Is there a chance? Is basically what I'm saying. If there's a chance we can resuscitate them and they can have a normal life and they can hug their kids and say good and They can hug their kids and maybe go back to work. I will give them that chance because I would want that chance myself. It's not my job to be a subjective provider and think, well, she's 90, she's lived a good life. This is true. I'm an objective provider, though. My job is to respond, assess viability, and if there is a patient in critical need of resuscitative efforts and they have no DNR, which is a do not resuscitate order, I have a job to attempt resuscitation. Would you want someone to try and resuscitate you or your loved ones? Would you want them to at least give you the chance? I remember this one call I ran, and ooh, it cut me deep a little bit in the moment. You know, I mean, afterwards, I went and drank it away. I'm kidding, I didn't. But this lady, like 65, she wasn't old, wasn't that old, and she'd been down a while, and we was able to get her back enough, and at least her family was able to come and say goodbye to her. You know, she wasn't going to live much longer past that, and they decided that since she was going to have to live on a vent and blah 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 blah, they were going to pull the plug. But at least the family could say goodbye, which was giving them closure of their loved one passing into the next life. CPR stands for cardiopulmonary resuscitation. Cardio, heart, pulmonary, lung resuscitation reestablishes circulation and reestablishes circulation and artificial ventilation in a patient who's not breathing, has no pulse. CPR steps include to restore circulation. That is number one. There is nothing more important than CPR, the chest compression component. Your compression should be 100 to 120 compressions a minute, at least 2 inches. At least 2 inches down, allowing for adequate chest recoil so the heart can refill itself. That has to be number one. Everything else is secondary. Any ROSC I've gotten on a patient, ROSC, ROSC, stands for return of spontaneous circulation. Any ROSC I ever got, it was because we made sure them compressions were perfect. It had nothing to do with the medicine I did. It was because somebody had some triceps from hell and they were giving it to me. I have never worked anywhere with a Lucas device. For you new EMTB students, a Lucas device is this supremely magical device that is a machine you can hook to a patient and do CPR for you. It does perfect CPR and it doesn't get tired like I or you would over time. I have never worked anywhere that had one though. So, next step we're going to do is open the airway. Again, one conduit. Sometimes an airway can be closed off, and the simplest thing, like a head tilt chin lift, can open that airway. Restore breathing, provide rescue breathing. Remember, we carry a device called a bag valve mask that can provide artificial ventilation to a patient. Now, remember, you have to have a seal on that mask. That C and that E we talked about before. That is what provides a seal. Clasp it down, grab it underneath the chin, and lean their head back just a slight bit and give a breath. If you have no seal, you have nothing. Could you perform a seal on someone like me? Not very well with this glorious beard I had. I trimmed it. It's much smaller now. But still, this would get in the way. So let's take a look at it. You must quickly identify the patient's in respiratory or cardiac arrest. So she's got her hands in there between the nipples, and the hands are perfectly aligned. Shoulders are over the chest, arms are straight. That's good looking CPR right there. I want to tell you, fellas, don't be trying to impress these nurses or cute little EMT girls that you be seeing. Don't be trying to put on the triceps show. This ain't about you right now. I've seen so many young dudes just out here just, here, girl, you see that? Triceps huge. But they wear out quickly and then they're useless to us in the EMS field. He's spent his energy. So what you do is you lock your arms, you put your shoulders over the chest and use your hips. It's all in the hips. My man behind her there, he's got the bag valve mask on the patient, hooked up to 100% O2. He's got the nice C and E there, a good seal on the mask, and he's going to probably be squeezing that thing with a compression to ventilation ratio of 30 compressions to 2 ventilations for the patient without an advanced airway in there. Now, when your ALS unit shows up or whatever, they can stick a tube down the dude's throat. Then we can give a breath every 6 seconds. But for now, only going to give 2 breaths every 30 compressions is what we're talking about here. BLS differs from advanced life support. ALS involves a cardiac monitor where I can manually defibrillate / electrocute a patient. I can give fluids, medications, advanced airways, all that kind of stuff. That is really the big differential between a paramedic and you, is their cardiac skills, IV and fluids and medications, and their advanced airway management skills. But BLS must come before ALS. Your BLS skills will be what saves the patient's life. Now, all that other stuff the paramedic can do, it is helpful. It is helpful. But decompressions and early recognition, that is solely BLS, and that needs to be perfect, and it needs to be on you. There is a chain of survival that will help you survive. Recognition or activation of EMS. We need to get the cavalry there, but that's going to be you. But what if you're over there at Lowe's picking up a load of lumber for $5 billion, because that's what it costs nowadays, and somebody falls out in front of you? Let me tell you now, quick, fast, in a hurry, I'm pretty good, guys. I've been doing this a long time. Mr. Larry's even better. He's been doing it way longer. Like, his first ambulance was a dinosaur with a wagon behind it. So, as good as anybody is, though, what is Picasso without his paintbrush? What is a carpenter without his hammer? You're a lay person at this time, even though you're medically trained. So if you're in Lowe's and somebody falls out in front of you, you've got to get the cavalry there. Now, I know most of us ain't more than a foot away from our cell phone, so get 911 activated. Go ahead and start that high quality CPR. Rapid defibrillation will save lives. The initial phase of the cardiac arrest is called the electrical phase. It's when the heart's sitting here quivering in ventricular fibrillation, and we can hit it with some electricity. Stop all that. Ooh, I'm sorry. I'm gonna go ahead and pump like I'm supposed to, and it'll get back to where it's supposed to do. So application of an AED is something you can do as a BLS provider in the layperson setting if there's an AED nearby. If not, high quality CPR and getting people moving to you. Getting advanced and basic life support to you will help a lot. ALS and post-arrest care is very important, and recovery is important. This chain of survival is using the entire EMS system, from your first responders, from your bystanders, from your dispatchers, from your paramedics and EMT pre-hospital, from your in-hospital care and after-hospital recovery units that some patients go to, like a rehab. It's using all of us. So AHA, chain of survival, is all of that. Again, I'm not, I just said it. So assessing the need for BLS is the same as anything else we do. We do a scene survey. As I survey the scene, I'm like, what do I need? How many patients do I got? First off, is the scene safe? Because I ain't going there if it ain't safe. Remember, the scene's not safe, thou shalt dippeth out. Give a shout. Amen. Amen. So always survey the scene, and it's a continuous process, not a one-time thing. Scene safety is not a one-time thing. It is a multiple over ongoing, let's keep it working kind of thing, baby. So remember the primary assessment, it is responsible for identifying life threats. During this time, I will be able to find if the patient requires CPR or not. So as I go through all my little steps, I got scene safe, PPE, BSI, MOI, NOI. Do I need additional resources? I would consider C-spine. I check the patient for general impression and life threats. I see a male 25 laying supine on the pavement. Hey, buddy, can you hear me? I'm checking his LOC now. He is not alert. He didn't respond to my voice. I give him a sternal rub. He doesn't respond. He's unresponsive. Now I need to evaluate his ABCs. I'm gonna do it quickly because he's unresponsive. I'm gonna look, listen, and feel. Looking for chest rise, listening for breath sounds, feeling for a carotid pulse. I will take at least 5 seconds to feel for a carotid pulse on the same side that I'm on. No more than 10 seconds. I feel no pulse. I make sure somebody either calls 911, or since I am 911, I begin CPR. We begin the steps of working this code. If I'm BLS, I call for ALS and I get more help to me, and we start getting the patient prepped and packaged for transfer. Now, we need to make sure the patient is viable and able to be worked. What does that mean? If the patient's missing a head, perhaps not begin CPR because it would be futile. There's that. If the patient's been incinerated and they're a crispy critter, perhaps not begin CPR. If the patient has rigor mortis and they're stiff like this and they're Frankensteining, they've been dead a long time. And unless you have supernatural power, they're not going to be coming back. So we need to make sure they're viable, they're able to be resuscitated, that they're within that realm there. So basic principles are the same for infants, children, and adults. You have to pump the heart and the chest, and you got to give them breaths. So he's showing us how to check out an unresponsive patient. He's shaking the guy, sir, sir. Now, I heard this the other day, and I don't know how true it is, but they're saying that the sternal rub is not humane. All I'm doing is compressing my knuckles into their sternum, and I'm looking for a pain response. I'm looking to see, are they full of crap or are they really in a deep, deep coma? However you want to elicit a pain response, that's fine with me. Sternal rub, a lot of the smaller people will take a pin on the nail bed, a trapezius squeeze. Somebody told me the other day that they're actually putting pressure against the eyebrows. None of it sounds extremely pleasant, but I'm just trying to check the patient's responsiveness. You're not trying to like hurt them. So what about an AED, automated external defibrillator? So an AED is simple to use. I would say it's even fireman proof. So an AED, we apply pads here. You open the box and it starts talking to you. The first thing you got to do though, guys, is turn it on. There's an on switch, hit it. Why am I saying that? Because there's somebody that has not before. It has happened. Don't let it be you, because I will find you. Even if it's been years and you're no longer my student, I will hunt you down and make fun of you. So AED. So the heart could be in a possible ventricular fibrillation or some type of abnormal arrhythmia. The AED can restore a normal perfusing heart rhythm by electrocuting them. So turn it on, follow the prompts. Turn it on, follow the prompts. Remove pads from package. Place pads on patient's bare chest. Analyzing rhythm. Do not touch the patient. Shock advised. Please clear the patient. You'll charge. Press shock now. All right, everybody clear? I'm clear. All right, move. Boom, shock delivered. Resume CPR. So it will prompt you and give you the steps to every bit of what you need there. Every little bit of what you need will be right there for you. Right there for you. Now, some things to remember about the AED, though, is this. It ain't going to work on a hairy chest. So if you've got hamburger meat like I do, but you're going to have to shave the patient's chest. In the AED should be a small little disposable Gillette razor or something like that. And you need to be able to shave the patient's chest. Upper right, lower left, enough for a pad there. Now, we say this in EMS a lot. If there is no razor, we need to get that hair off somehow. So if there's a spare set of pads, pad, give them a free waxing, and then put the other pads on there. But as much hair as you can move off the patient as possible. We're not going to sit here and pluck them one by one, but you definitely need to get the hair off of them and out of the way. So also, if you have a patient that goes into a pool, or you need a patient that's drowned, pull them out of the pool, wipe their chest, get them away from the water. Does water and electricity mix? No. So get them out of the water. Do not become a victim yourself. So children, after 5 cycles of CPR, use pediatric pads and dose attenuating system. If neither is available, then use an AED with adult-sized pads with anterior and posterior placement. So if there's PD pads, great. Put them in the right spots, upper right, lower left. If not, use adult pads, one on the front, one on the back. That's the best we can do. Something's better than nothing, right? So special situations would be pacemakers and implanted defibrillators. Do not put pads on pacemakers. You'll see it sticking up over here or wherever they've got it put at. It'll be a big nodular looking thing. Do not put this electrical thing on top of another electrical thing. Bad juju. Wet patients, dry your patients if they are wet. And transdermal medication patches, remove those. For patients to have effective CPR, it must be on a firm, flat surface. I cannot stand responding to a nursing home and they're doing CPR on the bed and the patient's just bouncing everywhere. How effective is that CPR, do you think? You're right. About as effective as a screen door on a submarine. Not very. So, firm, flat surface. So your spine board, the floor, but something firm. Must be enough space for 2 rescuers to perform CPR. I'm not proud of it, but I have grabbed a patient by the legs and my partner grabbed their arms and we just picked them up and moved them to where we need them to be for us to be successful at a possible resuscitation attempt on them. We still need more help. So I'm also calling for additional resources. Log rolling a patient onto the backboard, which we did this last week in lab, is a great idea. That allows you to do what? Move the patient freely with, where you need them to go, but also it gives you a firm, flat surface to push off of. We've already kind of talked about checking for pulse and breathing, so I'm gonna move past this right here. Compressions, we already talked about compressions, we'll move past that. So the heart lies right there. All right, here's a good example of what we're doing here. Compressions or relaxation should be rhythmic. We need to make sure we're allowing for recoil. What is that? You gotta allow the chest to pop back up. The reason behind that is if we're squishing all the blood out and not allowing it to refill, the patient will not have blood flow. Because why? It's not refilling. The heart's a spongy little organ, has to suck in new stuff as it spits other out. So this is a great area right here, the opening the airway and providing artificial ventilation. So in the first figure we have over here, let's talk about it. We've got the head tilt chin lift. We got the fingers at the bottom of the jaw right here. And we've got the head back being tilted back right here. You would only do this to a patient that you do not suspect traumatic injury on. Why? Well, let's look at this. If the patient might have been in a car wreck and you're trying to do a head tilt chin lift and they got a neck injury, what are you gonna do? You're gonna crack their neck even worse. So for any trauma patients, we have another maneuver we're gonna talk about in a minute. But if you're sure the patient has no trauma issues or no cervical spine injuries or no contraindication for you to do a head tilt chin lift, then you may go ahead and do it. So the most common obstruction is the tongue, and it blocks this airway right here, stops air from coming in and blocks it from going in the trachea down this way. Here's some lungs. Oh, yeah. So it blocks air from coming in right here. But by tilting the head back this way, we are able to move that tongue off of that bad. We are able to get that tongue out of the way there. So now we got the jaw thrust over here on the right-hand side. So we got the young lady right here laying flat. She is supine. We have a possible inclination of a possible traumatic event. So what we do is we do a modified jaw thrust. We put the head in a neutral inline position like this is right here. Her head is straight up and down right here. Okay, that's a terrible drawing, but whatever. So pretty straight right there. So what is my friend here doing, the EMS personnel? So they have patient's jaw right here, and they're just going to put pressure going upwards, going this way on that, pushing the jaw up and opening that airway, pushing the jaw up and opening that airway. That's all there is to it. Again, we're not manipulating that head or neck like this, like we would normally do, because we maybe suspect some spinal injury or some sort. Still have a little bit of erasing to do. So if the patient's adequately breathing and there are no signs of injury to the head, spine, hip, and pelvis, place the patient in the recovering position. Now, we spoke about this in one of our first lectures. The recovery position is the left lateral recumbent. This patient this is protecting their airway. It maintains a clear airway. If they puke, it allows it to drain from the mouth, and you can roll the patient as a unit. Let's take a look. This is our recovery position right here. Patient's on their side, leg is straight. This one's bent slightly, keeping them from turning over anymore. Their head is on the one side, and if they start to vomit, it'll come out this way. Main thing we want to protect them against is vomit aspiration. That means their fluid that they're going to puke up goes into their lungs, then they arrest, and it's more work for me or you. So this is a great position for patients that are what? We have no suspected spinal trauma or anything else. Patients adequately breathing. They are breathing. There are no signs of injury to the head, spine, hip, or pelvis. Place them in a recovery position. I also call this, not only is it the recovery position of the left lateral recumbent, it's also, for me, the drunk patient position. Why? I worked in Atlanta. Buckhead, Friday, Saturday night, there's drunk people everywhere. Sometimes we'll get a call up there. Hey, I'm sick. I'm gonna pass out now. Okay, you do that, baby. And I put them on that recovery position. That way they don't puke and aspirate, and then I got to work their airway. So a lot of drunk people have been placed in this. It is airway protected. That does not take the onus off of you. You still got to monitor them, maintain their airway, keep it open, check for any other illicit drug use, check their vitals, baselines, maintain ABCs, transport to a hospital. Now, this is a big topic of debate for, that might be a good discussion. You know what, I'm gonna ignore it. The topic of debate in EMS is why do we transport drunk patients? We get calls all the time from PD units. Hey, we need you to check this guy out. And we get there and the guy's not hurt. He has no complaints. He's just drunker than hell. And while that's unfortunate, it's not truly a medical emergency. What happens is we transport the patient to the ER and they get a bill. Some of the ERs, though, I noticed, don't always sign them in. They just let them sleep it off over there. They monitor them, and then when they wake up, hey, we're drunk. You sorry son of a gun. Go home. You need a ride home? I got a ride. And let's give you a cab. They were good about that in Atlanta. So that's a topic of debate. That why does PD call us for all these drunk patients? And I can tell you a lot of times on Friday, Saturday nights in Fulton County, because their jails were full, and they did not want to take the risk or the liability of the patient, having some type of medical issue in the jail unit. Big topic of debate there. So the combination and lack of oxygen and too much carbon dioxide in the blood is lethal. It will kill you. If patients not breathing, ventilations must be given by 1 or 2 EMS providers. Use a barrier device. Now here's a caveat. I ain't putting my mouth on none of y'all. You just die. I ain't doing it. I have seen what happens when you do that. When you blow air into the mouth, there are 2 pipes, esophagus and trachea. Some of that air is going into the guts. That gut will expand and eventually squirt back up, and the patient will vomit all in your mouth. Ew. So you're an EMS provider. You will give breaths via a BVM. Back in the day, they put mouth to mouth, and I'm not catching the Rona or anything else from anybody. My advice is to practice infectious disease control. We have BVMs, you will use them. And if you're a layperson at the time, I will do hands-only CPR as good as it can be done. I ain't putting my mouth on nobody. A lot of us have done it for babies, though. I mean, I'll admit to that one. And that was emotionally charged. You do you, though. If that's your decision to put your mouth on somebody, that is completely okay. I would advise a barrier device, like at least a plastic film that they give out, or if you have a BVM, probably better to use it. But you do you, player. You do you. So there we go. We got a good look right here. Look at this thing right here. So he's got her head tilted back. The C is perfect. The E, his bottom finger is gripping that jawline right here, and the jawline right here, and he is pulling it back, opening the airway so that air can flow from this BVM down into the lungs. That's really good right there. He's not trying to overbag the patient and blow too much in there and injure them. He is doing what he's got to do. He's doing his 2 breaths a minute. Squeeze the bag over a full second, squeeze the bag over a full second, just enough to watch the chest rise. Just enough to watch the chest rise. That's how it's done, guys and girls. What about the patient with a stoma? Now, this is a patient that has a tracheostomy, like a cut hole in the throat. You've seen that commercial. Smoking ruined my life. Smoking was bad, but I really enjoyed it when I did it. So that patient with the hole in their throat, right there. So they have a stoma. Place a bag mask device or a pocket mask directly over it. Artificial ventilation may result in gastric distension. Have suction ready because there's definitely some lung boogers down there that are going to come seeping up. So there's the patient's stoma. I think this is a cadaver. So right here is the stoma. Oh, change the color of this. It's terrible. Oh. I like that. I'm figuring things out, guys. I'm getting there. All right, so here's the stoma right here. There's a hole in this dude's throat. So the stoma connects to the trachea directly to the skin. Use a BVM to ventilate the patient through their neck hole. Again, some things better than nothing. So ventilate through this patient's neck hole. So we've already covered the basics of CPR. We've also covered the tenets of the metrics of it. Again, we're looking for 100 to 120 compressions per minute, at least a depth of 2 inches. We're looking for providing breaths via the BVM, enough to get a chest rise. We have talked about an AED and the AED's uses and its kind of hang-ups there. Turn it on, follow the prompts. If they're hairy, shave them. Where to place these pads. What about the choking patient? Now, the choking patient, we need to remember to do what? The choking patient, we're going to remember to do the Heimlich maneuver. Get behind them, and then you need to go give them a good Heimlich maneuver. So form a fist over the umbilicus, grab underneath above that thing and onto that fist, and you're going to give them some good old intra-abdominal pressure. That will pop that thing on out, hopefully quick, fast, in a hurry. You do that to conscious choking patients. Conscious choking patients. Only conscious choking patients. When the patient becomes unconscious, CPR. We're still increasing the thoracic pressure to hopefully pop that bad boy out. And every now and then, every minute, couple minutes, 2 minutes, check to see if that thing's popped out. And get it out so they can breathe again. Pediatrics and their choking. We have that 5 back slaps and then 5 chest compressions method. Flip them over, 5 back slap, flip them over, chest compressions. That's for a conscious infant or a child. When they go unconscious, again, we're going to do CPR. CPR. So BLS resuscitation, the steps that are important are recognition, immediate recognition, and then starting that process, that chain of survival. And this is really just feels like a CPR update kind of class. So I feel like we've covered the basics of it. If you have any questions, please reach out to me. Tomorrow night is a lab night for those that are coming. I think next week we got Savannah finally coming in. I'm going to send your command staff and admins some sheets though, Savannah. That way you guys can have some stuff to be practicing playing with before we meet up. That way we're not starting from scratch in lab. So I'll send that to them tomorrow. But other than that, these are the steps we got, what we're going over. And if you need anything else, please feel free to reach out.